Welcome. Thanks for joining me. Today we're going to be talking about some of the safe use of opioids, the concurrent e-prescribing for opioid prescriptions as the Kentucky statewide opioid stewardship program. I'm Ryan Stanton, board certified emergency physician as well as board certified in EMS as well. I've been involved with this for a very long time, since the beginning, and heading up a lot of the emergency medicine based projects. And the key here really is about decreasing risk mitigation for our patients, decreasing the burden of addiction, and honestly, treating pain better with the evidence-based pain management strategies. So let's jump right into it. So why is this actually important? Who gives a rip? So the HRIP is the Kentucky Hospital Rate Improvement Program, has incorporated several of the Kentucky statewide opioid stewardship program metrics in there. So there's actually money potentially tied to these metrics and being successful at these metrics. So there's not only the ethical and professional incentives for doing so, but also now the financial incentives as well. So that's always an important consideration. So why does it matter? Well, these are lives. This is the opioid epidemic. We are seeing improvements in the numbers across Kentucky and the country right now, but we are still well above any epidemic that we had seen in the past with regard to substance abuse related addiction and deaths. It is still a significant burden, especially for young people who have their entire lives ahead of them. And what we found is that we had significant misdirection in the late 90s and early 2000s with regard to pain medications. A lot of that because of the pharmaceutical industry. Other reasons were just in many ways laziness in terms of being able to get convinced, and then some of the metrics that were out there. Sometimes metrics are meant to improve patient care, but sometimes inadvertently they actually harm patients and harm patient care. And so the reason this matters is getting back to evidence-based medicine, evidence-based care of the patient. And that's what we're trying to focus on, is the idea that we went astray, we went off the path, and now we're just trying to get back course correct to evidence-based standard of care for our emergency physicians, walk-in patients, clinic patients, on the best ways to treat pain within our settings and to help our patients decrease the burden of pain while at the same time protecting life and decreasing the risk of addiction. But this isn't about zero. And I think that's one of the biggest challenges we've seen with the Kentucky SOS program, as well as the bridge programs. This is not about zero. This is not about getting to zero. This is about decreasing. And what we're seeing across the country is we can typically decrease about 80 to 90% from our peak in terms of opioid prescribing and still improve pain management and then significantly decrease the epidemic and risk for addiction and dependence. There are areas where opioids are incredibly important, whether it's in the immediate post-operative care, whether it's for cancer care, whether it's for significant traumatic injuries, or for some who may not be able to do some of the other therapies. There are important roles for these medications. So don't try to get your hospital and people to a zero mark. The key is to get them down to the numbers that we need to see, the most appropriate evidence-based numbers, just like we do with any other disease process, whether it's sepsis, whether it's stroke, whether it's STEMI, whatever the metric is to meet the metric as many times as possible within the constraints and the patient presenting in front of you. Because the key here is that this isn't about setting a rule and everybody following that rule to a T. It's about treating that patient that's in front of you and then their needs at that time. So for me, there is variation. I use very few opioids, but when it's appropriate, I will use them for that patient. All right. The big things is to keep in mind, or what is your EMR? That's the big thing. Most of us are under one or two that are popular. But what is your EMR? What are the functionalities in terms of when we're doing e-prescribing? What is the EMR and how easy does it make the workflow? That is the key. For us, our redesign for analgesia puts the Alto medication, so alternatives to opioids, primarily above it. And especially when we're dealing with the processes like kidney stones and back pain and ankle pain and those types of things, we're putting those non-controlled substances, non-opioids, well above the controlled substances. So they're first in sight first in mind. And you actually have to scroll down a little bit below the page to get to some of those controlled substances, because that allows it to be at the front of mind. That allows us to think that this is our primary. So looking at those and designing your EMR to put these at the forefront. But also with regard to e-prescribing is, what is the flow rate with regard to e-prescribing? Is it something that's easy to do? Is the staff putting in accurate pharmacy information? I'm amazed the number of times that when I do write a controlled substance, that the pharmacy ends up being wrong and having to do it over again. And then you have to have a call to the pharmacy to not fill that, because in our particular case, it is not set up to where it automatically cancels that prescription or pulls it back and is actually sent and already there. So the potential for having dual prescriptions out there, and not to say people would take advantage of that, but somebody would at some point. But in most cases, it's just having an unfortunate prescription at the wrong location. So keep that in mind in that flow rate. For me, when it comes to my prescribing, it takes me about 16 to 18 clicks and different steps to get through to write a controlled substance. Not ideal, but at the same time also, it's another trigger that says you really have to want to do this, and this really has to be purposeful to go down that pathway. Is Casper integrated? That's the biggest thing. If it's so, is it acknowledged in the EMR? So for us, when I open up Casper, so the PDMP, I review it right there. 95 to 98% of the time, it gives me the report I need, the prescriptions that are available. That program has gotten so much better and so much more up to date, and it's right there. And I can acknowledge it. That goes in and fulfills our metric in terms of reviewing for my facility within the EMR. So I stay within the EMR. I don't have to go separate and log into the program. The key here is that having that integrated and easing the workflow for your physicians and non-physicians is very important in terms of the prescribing and avoiding one of the most common things that we're seeing now and looking at from an opioid prescribing council and on the state level. It's that co-prescribing or overlapping prescriptions. So making sure that you're reviewing that, looking at the patterns, looking at the risk factors, and actually taking notes of making sure that you're doing what's best for the patient. And are there non-physician practicing in the ED? So, there is some latitude within the state for that, but at the same time, are there non-physicians? Are they reviewing Casper? In my case, they don't have access to the Casper on theirs. And so when they send a prescription, I have to review it, ensure that I'm reviewing the Casper PDMP and talking with them about, is this indicated? What are the concerns I may have? Is it appropriate, or are we going to change it up? So this is where the physician needs to be very involved with the patient, and because of the education, because of the experience, and because of the responsibility, honestly, the laws that are on the books, the statutes and regulations that are on the books. Are there non-physicians working there, making sure that you're overseeing what they're prescribing, what they're writing in the hospital, what they're writing in the emergency department? I still see a fair number that will jump right towards opioids for kidney stone pain, and that's simply not the standard of care anymore. And then rarely, don't see it really much anymore. I think we've really gotten that out of our system, is the opioids, even any controlled substances for migraine headaches. But monitoring that, and is it an opportunity for education with these folks to make sure that they're doing the standard of care? Now, this one came out in June of 2024. For the second year in a row, Kentucky overdose deaths decreased, and that was through the 2023 data. 2024, based on 2025 data, actually decreased as well. We were one of the first states after COVID to start to see the numbers trend down once again. We are seeing significant drops in those numbers, thankfully, due to the efforts of many people across the Commonwealth, from all levels, really trying to invest in the human beings that are impacted by the opioid epidemic. And so we've seen those numbers trend down, and we've also seen them start to trend down in most of the country as well. So a very good sign, but still a lot of work to do. So looking at some of the death rates here, the number of deaths, and of course our city centers, Lexington, Louisville, Central Kentucky, getting into some of the larger cities in Eastern Kentucky is where the deaths occurred in 2023. That's expected. Of course, now it's not necessarily what we were seeing 20 years ago with the prescription opioids, was the transition now to heroin, then fentanyl, and then some of those analogs that have been started to be placed in there. But the key is many of these folks that are dealing and struggling with dependence and addiction, that started in the emergency department or the hospital setting or in a healthcare setting. So we have a role in risk mitigation for decreasing that risk or even prescribing, because the other source is a family medicine cabinet, something at the house. So the education on disposing of the medications, writing the shortest course possible, and all of those types of things will decrease that risk. One of the big things is avoiding concurrent prescriptions. Now, this is a big focus for the state right now, and looking into some of these highest folks of whether it's being reviewed, PDMP is being reviewed, and then whether there is concurrent or overlapping prescriptions. So this one, avoiding the concurrent prescriptions, has to do with patients 18 and older. All right, so that's our pretty typical. It's e-prescriptions with 2 or more Schedule II opioids or 1 Schedule II plus a benzodiazepine. This is one of the metrics that we're dealing with right now within the Kentucky statewide opioid stewardship program, and that's what we're talking about with regard to the e-prescribing. And the key here is that access to the PDMP. Can I review it and know that this patient has that risk with it? And remember, there are situations where there is the potential for an overlapping prescription. There is a co-prescribing, but having to explain in your chart in there why you made that decision. If you look at the statutes that have taken place over the last number of years from the state level with the statutes and the regulations, most of it involves guardrails on prescribing, but at the same time allowing prescriber latitude to treat the patient in front of them, with the key being that you have to make that explanation in the chart as to why this is different and falls outside of that realm or outside that consideration. So for this metric, patients 18 and older, e-prescriptions, 2 plus Schedule II opioids, or 1 Schedule II plus a benzodiazepine, because we know that any of those things that happens, the 2 plus or the 1 plus 1, increases the risk of dependence, increases the risk of overdose, and increases the risk of a poor outcome, and the number needed to harm is quite small. So here we go. That's the measure of success. The numerator is the patients 18 plus, e-prescriptions, 2 plus opioids or opioids plus benzo. That's what we just talked about. The denominator is the patients 18 plus, e-prescriptions, Schedule II opioids or benzodiazepines. The inclusion is the history of cancer should be included. Now, if it's active cancer, then that's not the case. That's an exclusion. But history of cancer, theoretically in remission or not active treatment, then that is one. So it's very important when you're doing your discharge is to accurately put in your disposition, if they have cancer, that it is current cancer, because with regard to billing, in regard to the way things are seen from a billing and coding standpoint, history of suggests that it has been corrected, that it's been fixed. And so history of, in this case, suggests that it's not actively cancer. So active cancer exclusion is going to be active cancer currently being addressed in this visit. Palliative care patient as well. Continued home medications, things like that are considerations as well. All right. So measuring goal Q4 of 2023, 5% decrease from hospital baseline or achieve Kentucky baseline average or better. Q4 2023 was the 10% from the hospital baseline or achieve Kentucky baseline average or better. So that's the key here. This isn't about, one thing I don't like about a lot of the patient satisfaction is the fact that it's not really how good is your patient satisfaction. It's really kind of a battle, a war between practitioners and EDs and hospitals and those types of things, because at any given moment, the coin has to have a heads and a tails. There has to be a winner and a loser. It has to be a positive, and there has to be a negative. This is about your baseline, establishing the baseline or the Kentucky baseline average or better. And so what we're looking at is that drop in those uh, dual prescribing and overlapping prescriptions. And so it really is something that is looking at your practice, your setting, and improving compared to that. Or if you're already in a great place, it's how are you compared to the state baseline. And so this is a measure that is written for success. This is written for you to be able to succeed and to celebrate your practitioners, your physicians, PAs, NPs, staff, and facility that invest, do the education, and improve the safety for the patients. So what's already in the mix with regard to the legislation and things that are out there? It's the CASPR, the chronic pain, the 3-day course. Can't be replacing prescriptions. I don't see a lot of that anymore, thankfully. No long acting. We're still focusing in the acute care setting, emergency department setting, walk-in setting on short acting. This is an acute episode of pain. That's the theory. This is an acute episode of pain. You don't need long acting opioids. We know that increases the risk of dependence, overdose, and bad outcomes. The education and consent, informed consent with our patients before these, as well as the treatment. So all of these things are already in the mix. They've been in the mix now for a really long time. It's just that we have continued baby steps, because as I always say when I do these talks, if you've seen one before, it's much harder to remove a bad practice than it is to have never done it to begin with. So the practice and what we saw in the late 90s and early 2000s with the education and misguidance with regard to opioids really is something that's been very difficult to reverse, and especially when it comes to convincing and educating patients on the expectations as well. All right, the easy button, review the CASPR. Got to do it every time. The rules are there. It's simple there. I was amazed when I reviewed, some of the hospitals at how many physicians do not review the CASPR when they are giving or prescribing opioids. This is huge. We have the system. I understand that when CASPR was new, it was clunky, it was slow, and it had a lot of holes in it. That's not the case anymore. It's been really tightened up. The reporting is pretty efficient, and so the data there is really good. And not to mention, especially on our bordering communities, the number of shared amount of information that can be shared, and we can see things such as if you're in Louisville, what is their Indiana status? If you're in northern Kentucky, what is the Ohio status? If you're down in southern Kentucky in the Bowling Green area or Middlesboro, wherever it may be, looking at some of the Tennessee data. And so, making sure that we are looking at that data to make sure that we're doing what's right for the patient. That's it's accurate. On occasion, you're going to get one that says it's not available. In that case, I will open up the full program and go in and see what's available. If it's manual process, then I am very hesitant to prescribe an opioid unless it is an obvious acute issue that it's really doesn't matter what I'm going to see. I just make sure that I explain it well within my chart. So make this the easy button. Hospital administrators, make sure that CASPR is an easy to access program within your EMR and for everybody in your system, so they can look at it and make sure that they've got the most up-to-date data with regard to the prescribing patterns. And now with a lot of the EMRs, and in our case, the ED pharmacist, they can pull a lot of the most recent prescribing data and things that are out there and actually pull some of the more, the other medications and things that can get in as well. All right. This is really about evidence-based care. It really is evidence-based care. The preponderance of evidence now is that opioids are rarely a first-line agent. Rarely. For the vast majority of things we see in emergency medicine, non-opioid approaches are the key. They are the highest success, the safest way to treat pain, and honestly, in the end, patient satisfaction, patient recovery, patient returning to function. That is the key here, is we want the patients to be able to return to their normal lives as quickly as possible, and the evidence is out there. So when I'm treating a lot of the acute pain, let's just say kidney stone. They're going to come in, they're going to get their NSAID, maybe it's a ketorolac. They're going to get the acetaminophen. I love putting a lower dose of the NSAID and the acetaminophen together to allow them to have that symbiotic relationship, remembering that NSAIDs do have a therapeutic ceiling, so we don't need those huge doses of ketorolac, and we've talked about that. It's typically a 7.5 to 15 milligrams in terms of that. Looking at some of the fluids, looking at some of the adjuncts. When it's regard to fractures and fracture care, it may be more of a regional nerve block. Those are becoming very accessible. We do a ton of femoral nerve blocks for our elderly patients just because of the sheer risk of putting them on controlled substances when they're in the hospital. They're more comfortable, they rest better, and they recover faster. And so learning those and having access, not to mention as that procedure and the increase in the medical decision making and the opportunities there with the bedside ultrasound and POCUS within emergency medicine. So this is evidence-based medicine, and that's what we're driving for. And the benefit of evidence-based medicine is decreased deaths, decreased addiction and dependence, increased chances of recovery, and overall better care. All right, so here's the wrap up. Let's bring this thing home pretty soon here. Keys to success: more is not better. When I talked about the NSAIDs, the therapeutic ceiling, when we're talking about opioids, it's not always about more. If there's somebody's already on chronic, think about some of the other alternatives because it may not be an opioid. That's the choice. Alto principles still apply. And the alternatives to opioids, there's a ton out there right now. Treat the cause, not the symptom. I think that's what we do so much, and that's what opioids do, is they treat the symptom. They treat the expression of that. They don't treat the source. When I'm treating back pain or I'm treating kidney stones, I'm treating the source. With kidney stones, it's the ureteral spasms and the irritation of the stone and the blockage associated with it, with a mace ball basically going down the ureter. I'm treating the source of that pain, the back pain, the inflammation that's taking place, whether it's an ankle sprain with the inflammation and swelling, so getting some pressure on that. Looking at some of the other things, look at some of those things that are going to increase their long-term success. With back pain, there's a ton that's going to be done with other sources such as physical therapy, exercise and strength training, focusing on that as well. Some of the dry needling and acupuncture type things. There's a lot of things out there that we can do that we don't utilize enough in the traditional healthcare system. And part of my education with my patients is this isn't about zero pain. This is not about getting to zero. That was one of the biggest fallacies in the early part of the opioid epidemic, was everybody deserves to be pain-free. Pain serves a purpose. Pain is the metric by which our body says, don't do something, or you shouldn't do something, or something's wrong in this area. And if we allow people to be pain-free, then there's the chance they're going to make that worse, that they're going to exacerbate it, that they're going to turn it into a bigger issue. So pain has a purpose. What we want is for people to be comfortable, to take the edge off, to allow them to function, to allow them to get sleep. And so setting that expectation that we're not going for zero. In many cases, we do get to zero. In many cases, we're going to make the symptoms go away altogether, especially with kidney stones. But it isn't necessarily about that, and setting that expectation and education with the patient. And again, if there is a reason, let's look at chronic kidney disease. Let's look at, whatever the issue may be. Looking at some of the GI bleed stuff, just explain why this is different. And it needs to be clear in the chart as to why this is an outlier, why you thought about it, what you considered, and what you did instead. Now, that being said, if you have one practitioner that's explaining 50 to 60% of their patients and is still an outlier, I think having that information, letting your practitioners know where they fall on the bell curve with regard to prescribing, because we should all be kind of in a very similar area. If we're practicing at the same facility in the same location, our practice patterns and prescribing patterns should be pretty close. We got the information. One of our people was an outlier. They didn't even know it. They course corrected, adjusted, and the next month they were well under that bell curve as well. And so the key is we want everybody under the bell curve, and then we want to move that bell curve down more towards the evidence-based rates of prescribing that we expect to see. All right, keys to success: get the baseline. Your practitioners need to know where they sit. You need to be able to monitor that baseline. You need to know where they are and areas of improvement. Education is key. Helping folks understand why this is important, just like this talk today, is about education. It's about getting information out there and helping people understand why this is a better approach, why you need to change practice. Monitor the progress. Apply feedback. Celebrate success. If you get a 5% decrease or 10% decrease, celebrate that. Let folks know we are in a very difficult time in our healthcare system, and a lot of folks right now are struggling to even show up to work. We need to help celebrate the successes, because when these successes take place in your emergency department or in your urgent treatment centers or wherever it may be, you're saving lives. And most of us got into medicine to improve and save lives, and this is our opportunity to do just that. And then address outliers. If you've got somebody that's sitting well outside the curve, understand that that needs to be addressed, not only for patient safety, but also for their education. Hopefully they can fall under the bell curve. But at some point, if somebody persists, if somebody pushes back, and not to say physicians ever push back against anything, it's the fact if they push back or if somebody's not willing to understand evidence-based care, there may have to be corrective actions taken place. I've seen situations across the Commonwealth, especially working with the state level on things, on physicians that just simply refuse to understand the impact of opioids and evidence-based pain management. And there are reasons for some outliers, but some folks just simply are anchored in an unfortunate practice pattern, and that may have to be addressed on a larger level. But I think what I have found, the vast majority of physicians, PAs, NPs, hospital staff, whatever it may be, are very interested in understanding where they sit with regard to their peers, and then wanting to make sure that they are doing the best evidence-based medicine. All right, this is a team sport. This is for all of us. This isn't just physicians. This is physicians, non-physicians, our nurses, our pharmacies, our hospitals. It takes the administration. Administration will set the tone, and no project will be successful without significant administrative support. And that is variable across this Commonwealth. We need to, as administration, if you're watching this, you need to make sure that you're supporting your ED staffs and environment to do these metrics, to get the evidence-based medicine, and not with a stick and not with punitive measures, but with support and celebrating successes and resources and giving them the tools they need to succeed. All right, set the expectations. Again, a lot of the questions I get happen to do with these expectations, like getting that to zero. That has to happen every single time. There's no variability, and that's not the case. Again, Kentucky SOS, statewide SOS, is not about zero. It's about appropriate. And so that's where we are driving. So here's the expectations. Establish the culture, supportive culture, top-down supportive culture on making these changes. Reset the expectations with patients and families and staff. What I find, a lot of the questions come from our own staff of why I do things the way I do them, and helping them understand, and they're like, oh, that makes complete sense. Spending an extra 30 seconds with the patient to understand, to help them understand why I'm prescribing and how that may be different. Address that. Every time I come in, this happens, or I get this. Well, that may not be the best for you. It may not have been wrong for the moment, but at the same time, here's what we're going to do now. Sit down conversations. It's not about what you can't do, but what you are going to do to help them. And a lot of times it's as simple to me as, would you like for me to help you feel better and get back to your life faster? Or is it just about an opioid? And that's a very different conversation. Let them know this is about the health, recovery, and safety, that this is about them, their benefit. Secondarily is our benefit, but their benefit is really what this is all about. Expected course of symptoms, follow-up, and recovery. Let them know the plan. If it's a kidney stone and they pass the kidney stone in the emergency department, give them the information that you're likely still going to have symptoms off and on for about 24 hours, even though you pass the stone, just because of the damage and irritation of the ureter. Help them understand the mechanism and what they can expect to happen, because many people come to the emergency department not because of the problem, but because of the unknown around the problem. And information is what people need to succeed. Shared decision making. Make sure that you got the patients and the family involved, that we're involved, that they agree. Sometimes they may not agree, but I'm going to tell you the vast majority of time they will be on board and they agree with you. I find now our culture has shifted to the point that most people want to avoid pain medications, but we still have some that still think that ibuprofen and acetaminophen are not a pain medicine. Those are just for fever. We have to help correct shared decision education. Understand that some people just aren't there to get better. We have the folks, and those people are going to be dissatisfied, and they may leave, and they may not come back to your facility. And I'm going to tell you that sometimes that has to happen. We can't cater to those that are not here for evidence-based medicine. If they are here for something else, which is bridging an addiction, dependence, whatever it may be, shopping around, sometimes tough love is the best type of love. But that also gives us the opportunity in some of those to discuss and address recovery and maintenance and recovery and emerging from that. And that's a completely different talk with our Kentucky Bridge programs. But the opportunity to say, listen, this is where you are, and I'm sorry you've been in this situation, but we have an opportunity for you to improve, to get better, to recover, and start a path that does not involve these prescriptions or these street-based medications. And I can't stress enough administrative support. If you want this to fail, administration needs to be negative, apathetic, or non-supportive. If your administration supports, engages, and applies, supports the environment, gives the resources necessary, this will be successful. And better than Pizza Party is really truly supporting your staff that's coming in and providing the care 24/7, 365 in difficult environments, giving them that support and letting them know you care, and helping them, giving them the tools to be successful will make this program successful. Now, you do have to have occasionally the stick in the back pocket for certain situations, but that is not the way that we build successful programs. All right, so I welcome questions. Sorry for many that this is delayed. The first time we did it, apparently the audio didn't come across. So this is something I'm redoing here. I want to make sure that we are successful, but I'm always available. You can contact me through the KHA. Any questions we will cycle through. Happy to come do individual education, do virtual education, address questions that you may have, challenges that you're facing, because at some point over the last 20-something years, we've seen or heard it all. And we want everybody to be successful, because with that, we save lives, decrease disease burden, increase satisfaction, and increase the appropriate treatment of pain in our emergency departments. Great opportunity here, and it's a win all the way around, from our hospitals to our systems to our emergency departments to our practitioners to the patients to the families to the communities. It's a win all around. Thank you very much. Appreciate it. Have a good day.